Thank you, Ricardo. I have the pleasure of introducing three gentlemen who I've known for as long as a couple of decades, who are experts in this field. And Eric Rosow, who will be our first speaker. I've spent extensive time following September 11th and leveraging Eric's extraordinary pioneering effort in the convergence of clinical technologies with information technologies. I've worked with Axel Wirth since the US EMR, HITSPI, and AHIC projects 15 years ago, working. And then in terms of for the past 6 or 7 years working with Derek. Derek Ritz is part of the IHE International Board and brings an extraordinary understanding from the Canadian perspective and the work done with low and middle income countries. They each have a remarkable career story to tell of the impact and contributions that engineers can make in the healthcare field, and especially the convergence of clinical engineering technologies with digital technologies and the delivery of 21st century digital medicine. Let's begin with your journey, Eric, if you would please tell us about the work you've done and the progress that you've made in the work that is you're undertaking today.
Wonderful. Well, thank you so much, Elliot, and thank you to the IFMBE for the opportunity to join you this morning. It's a great honor. If we could go to the next slide. What I just set my stopwatch here, so I'll be sure to keep within my allotted time limits, Tom, and if not, I know you'll text me on the message board here. But wanted to quickly cover really the exciting world of convergence between CE and healthcare IT, as Elliot alluded to, touch on a little bit of why and how medicine is big and frankly often very dirty data, talk about some of the converging forces that we're seeing in our world, and the promise of what we call true clean digital semantic interoperability in data. And then wanted to wrap up with just some lessons learned and some references that I found to be very useful in my journey. So when we talk about convergence, I was fortunate to spend many years at Hartford Healthcare, really working closely with IT and partnering with IT and clinical engineering and really working together, which fostered and sparked my passion for the synergies and frankly the systems engineering learned by being a clinical engineer and how that can be applied to the world of IT and frankly to building a new venture. Next slide, please. So I was fortunate to have been exposed to a really interesting technology back in the late 80s called LabView. It stands for Laboratory Virtual Instrument Engineering Workbench. And it really showed the power of using analog to digital conversion, where you can actually create software modules to have all the same form and function of a traditional instrument or device. And so it's that convergence of true virtual instrumentation into instrumentation bi-directionally that sparked my passion for the world of IT. Next slide, please. And one of the books that I've read, many of his books, is by a guy named Guy Kawasaki. Guy was actually an evangelist for Apple in the early days, and he coined a term called Evangeneer. An Evangeneer, he defines as a combination of both an evangelist and an engineer, and it's someone who wants to change the world, but also has the technical knowledge to do it. And I would submit that all of us as clinical engineers and clinical engineering specialists have that capability, and that we understand how things work and why, and the ability to apply a vision to make that a reality. Next slide, please. So real quick, just touching on medicine, depending on your definition of big data, one could argue medicine is big data. I won't read each of these points, but when you look at the number of codes and concepts and medication codes, and then when you map them to each other, you have tens of millions of what we call semantic relationships. And across that, as Ricardo pointed out in his opening remarks, there's quite a bit of variation in the way those get translated. So if we go to the next slide, I wanted to speak to some of the challenge that we've seen here in the US, and that typically there are over 1 billion encounters per year among patients. What's even more interesting is even though we're in what we call a post-meaningful use world, there are actually over 4 million clinicians every day in our country documenting care in different electronic health records, and perhaps more importantly, different instances of those EHRs. So even though Epic or Cerner or some of the popular EHRs exist throughout much of the country, there are actually over 100 other certified electronic health record vendors, And one version of Epic is not necessarily the same instance or format as another. And so with that, we have thousands of attributes per encounter and what we collectively call just dirty clinical data or dirty data disorder. And then Ricardo also touched on the silos of data, and it's not uncommon here in the States that a patient, particularly a Medicare or chronic patient, may see 10 or 12 different care providers over the course of a year, often in different settings, and often with different EHRs. So you could have a primary care visit within Allscripts, another specialist within Athena, a hospital stay in Epic, a post-acute care captured in Cerner. And so how do you take all that silos of data and integrate it to get a true longitudinal view of that particular patient? Next slide. And we've kind of called this the Wild West of coding. This is actually a real world example in the background of literally hundreds of different ways in which something as basic as a hemoglobin A1C has been collected and documented. And you can see there's different syntax, there's different descriptors, there's different concepts. All of these get coded in different ways. And so how can you do true analytics or AI or machine learning when you have such variation among the individual source of data itself? And if we go to the next slide, that's really become our mission to empower this healthcare ecosystem by making this data universally accessible, organized, and actionable, and pulling in that original data, putting it through what we call our Refinery, or our NERDs, stands for normalize, enrich, reorganize, deduplicate, and summarize that data, and then output it so it truly is usable in the form of clinical data for analytics, pop health, use cases for payers, and others of the like. And next slide. We've also been living in, and in the last several months, seen an acceleration of a number of converging forces. So there's, here in the States, CMS and the Office of the National Coordinator have driven interoperability regulations, which I know Elliot and others have been very active in. There's administrative burdens, what we call friction and abrasion of actually just getting care delivered and documented. There's an array of net new sources, including devices that we all work in. There's obviously the global pandemic of COVID-19, which in many ways has been a time compressor of needs for digital charts and telehealth. There's, again, as I touched on, high volumes of data. And then there's customer satisfaction, the ability as consumers with our smartphones to be able to get all of our clinical and claims data in a single interaction is something that the market's now demanding. And next slide. So some of you may have been at the HIMSS conference a few years ago. The then CEO of Google, Eric Schmidt, gave a really compelling keynote. And as you can see here, at the end, he concluded to say that what we need is what he calls a second tier of data, and that the primary data stores in the electronic health records in the medical systems need to be supplemented, not replaced or supplanted, but supplemented with this second tier of data. And this is a key architectural point that he, in his 40 years of being a tech entrepreneur, has seen happen in multiple industries. It certainly is true in healthcare as well. So to give a real world example to that, if we go to this slide, we're all familiar with tools like Apple Maps or Google Maps or Lyft or Uber. All of those work superbly at scale because there can only be one GPS location for a destination. There can't be 100 different ways in which we define congestive heart failure or a hemoglobin A1C. And once that normalization has occurred, it allows developers to be very innovative and not spend time normalizing the data, but taking clean data to build algorithms that are useful like Lyft and Uber. If we look at how dirty healthcare data is, you can see in the bar graph on the right, it's crazy when you think of it, at least here in the States, literally 80% of the allergies are not coded properly, and 30% of them have no codes at all. Or 70% of lab results don't use the right vocabulary or proper units, or are not mapped into the proper LOINC library. Almost half of them were not. And almost 40% of medications don't have the right coding to do quality measures. So it's virtually impossible to do all the exciting, sexy things with analytics if you're starting with just very dirty and incomplete data. Next slide, please. So this is a Gartner report came out a few months ago, and they've basically reiterated this, that clinical data has an infinite degree of variability. As such, deriving meaning from this clinical data can seem like an insurmountable challenge, that folks need to work with process demands and look for assistance with folks that have spent a lot of time focusing on normalizing that data. Again, that's been our mission. And if we go to the next slide, we can see this isn't just in a silo. This is something that's making the headlines of the Wall Street Journal and the news and the media. And again, we touched on errors in healthcare, oftentimes due to poor data or lack of interoperability. The information, and why are companies like Google and others moving more and more aggressively into healthcare? Because it truly is an area of great need and frankly, great opportunity for improvement. So if we go to the next slide, we recently hosted a panel, and one of the health plan executives said something like, there's nothing like a good crisis to turn off the paper, which in some ways has really accelerated the needs for what we call digital charts. So if we go to the next slide, we can see some of the dynamics at play. I touched on telehealth. We touched on the need for actionable clinical data. And at least here in the States, it's very difficult to go into hospitals or care providing environments and literally pull paper charts to get a complete view of a patient, whether it be for life insurance underwriting or care delivery. And so this whole notion of the acceleration of what we call digital charts is something that we're very excited about in the ability to provide a longitudinal view of a patient. If we go to the next slide, the foundations of this are taking all this data, which has been digitized in a variety of EHRs as shown on the left. We have almost universal adoption here in the States for EHR adoption. But again, the way charts are retrieved does vary substantially depending on the EHR and the source and the workflow. And there's different standards ranging from HL7 to continuity of care documents to the new FHIR standard to extract that data in digital formats. And so really, how do you pull all that together from multi-source data while providing provenance of that data from source to target is really, really important as we go forward into this digital chart arena. Next slide. And I won't go through all of these, but I just wanted to highlight these. Some of these are more specific to payer use cases, but you can see that there's both real-time, ongoing, and retrospective analytic opportunities in which clinical data, particularly delivered digitally, can provide a whole host of improved workflows from utilization management to gaps in care, to risk adjustment, to what's called HEDIS reporting for quality outcomes, population health, and even consumer access, as well as payer-to-payer exchange. So here in the States, come January 1 next year, as a member of a plan, I can go to that plan with my smartphone, and the payer is required within 24 hours to provide me all my clinical and claims data in the form of a FHIR R4 standard that can be then consumed into my app. And you need to have normalized clinical data to do that, or else you're just going to get a whole bunch of dirty, messy, repetitive data. And so that's really an exciting opportunity that's being driven now, not just by customer need, but also by regulatory requirements. If we go to the next slide, we can look back in history and see that there's in fact evidence of this happening back starting in 2008, where people were then still prescribing medications on paper forms. And within a 6-year period, we went from almost 0 to 100% adoption of EPrescribing. We believe that same thing is about to happen now, particularly accelerated by COVID, given the world of digital data and the need for what we call a clinical data clearinghouse. If we go to the next slide, again, there's so many areas that the promise of clean data, not just digital data, offers opportunity. It certainly can lower costs and improve quality of care, operating expenses, information sharing, but it can also improve the top line in terms of having better quality measures, improving HEDIS and star ratings among payers, optimizing revenue to make sure you're allocating resources to the right areas, the right high-risk patients. It can most certainly increase precision and the opportunities around telehealth, but also those environments of machine learning and AI really can't realize their promise if they don't have clean data to start with. And then finally, for the consumer and the caregiver themselves, it improves satisfaction. So with that, I just have 2 final slides, final thoughts. If we go to the next slide, a couple quick reflections on lessons learned in just starting a new venture and scaling a company. My 5 bullets that I think I've really gravitated to is 1, putting in the time, not trying to move too fast, and really understanding a market. I think being clinical engineer professionals, we're on the front lines of seeing where there are gaps, problems, and opportunities. I've also learned the power of building the right team. That doesn't just mean the operating team, but also your board, your investors, staying focused and not trying to raise too much money too soon in the journey. Last comment, I think every great entrepreneur creates other entrepreneurs. That's the ultimate product. And I've listed a couple of books that I've really valued over the years. And my final slide, and I'm coming up on 5 seconds till my expiration here, Elliot, is from a film, Back to the Future, where Doc once said, your future hasn't been written yet. No one's has. Your future is whatever you make of it. So make it a good one. So with that, I hope this was helpful, and I turn it back over to Elliot and the rest of the panelists.
Thank you, Eric. It's always a pleasure to work with you. It's inspiring to reflect on all that you've contributed and all that you continue to contribute in this field. And we will be back to you for more guidance as this field continues to grow.